we'll go ahead and get started, and then so would invite you all to go ahead and introduce yourself in the chat with your name and your organization and your role, and I'll bring up our materials for today. Yeah, so thank you all for starting to introduce yourself in the chat, and then hopefully you all can see the slides. So just to start off again, good morning, everyone. Margaret Brandt, Assistant Deputy Director for Health System Performance here at the Office of Healthcare Affordability. We're excited to have this meeting today to provide an overview and an update of our APM standards and adoption goals and our primary care benchmark recommendations and the advisory committee feedback we received on those proposals yesterday. And of course, joining me this morning are members of the OHCA team and our partners at Friedman Healthcare. And as I noted, our main focus of the agenda today will be reviewing our APM standards and adoption goals and the advisory committee feedback we received on those, and then also our primary care benchmark recommendations and advisory committee feedback there. And we've provided some initial responses to advisory committee feedback and look forward to discussion and any additional thoughts you all have. And then to wrap up, we'll discuss our plan or kind of initial ideas for transitioning to measuring, defining and measuring behavioral health investment. So we're looking forward to transitioning a bit more to focus on that work, and especially starting in July in our work group meetings. So just a reminder again, as always, of our format. And would encourage you all, when you come off mute to speak during our discussions, please introduce yourself and introduce yourself in the chat. And I think with that, unless there are any updates or questions, we'll move to our first agenda item on alternative payment model recommendations and advisory committee feedback. So I'll turn it over to Nan to walk us through this portion of the agenda.
Thanks, Margareta. Next slide, please. Good morning, everyone. I would like to share an updated timeline for finalizing our alternative payment model recommendations. Last month, we reviewed a revised draft alternative payment model standard adoption goal with you. And then this month, we are reviewing the feedback from the advisory committee before presenting the final recommendation to the board for approval during the May 22nd board meeting. Originally, we planned on seeking board approval in June, but have been asked to seek board approval in May due to some of the board members' schedule. So if the board does not approve the recommendation in May, we'll come back for board approval in June. Next slide, please. And for reference here, we have included the APM standard on the next couple of slides. This group is already familiar with the standard, so we won't walk through each one. On the slides are standard 1 through 5. And then our next slide. And then here are standard 6 through 10. Next slide. Yesterday, the advisory committee provided some additional feedback on the APM standard and implementation guidance. Just to recap, 2 members suggested adding a standard that requires APM to be actuarial sound. We appreciate the focus on protecting access by ensuring payer and provider can continue to deliver care. In implementation guidance 5.3, we included reference to assuming financial risks that protect financial solvency and support sustainability. Next, several members noted the importance of emphasizing the value of PCP consumer relationship and the continuity of care in the standard. OHCA agrees that strong relationship between consumer and their primary care teams is critical to the success of APMs. Implementation Guidance 3.4 highlights that APM arrangement should encourage consumer to choose a primary care team. Also, implementation guidance 3.1 notes the importance of providing sufficient payments to primary care to support primary care continuity. One member suggested collecting information on the adoption of APM standard and implementation guidance to understand and share how care delivery and payment are changing. OHCA will consider collecting information on implementation of APM standard in the performance improvement plans. Next slide. Several members also supported the inclusion of technical assistance for small practices to adopt APM and suggested payers should also provide funding to support small practices adopt APM. So in Standard 10 and Implementation Guidance 5.1, we reflected these themes. One member suggested presentation by the California Quality Collaborative and others who are leading collaborative effort to expand APM adoption among PPO plans. OHCA will consider opportunity for presentation from stakeholder and as well as other way to disseminate best practices. One member noted the importance of meaningful data sharing, supportive benefit design, such as PCP assignment and other features to support APM adoption in PPO plans. The OHCA team agrees and incorporate these ideas through the standard and implementation guidance to support provider ability to engage in APM. Next slide. So now we will discuss OHCA revised APM adoption goals. Please note that these revised adoption goals are also under discussion with state sibling departments. OHCA revised goals set 2-year goals across 10 years that differ by payer and product type. OHCA is proposing a final 10-year goal of 95% for commercial HMO and Medicare Advantage, 75% for Medi-Cal, and 60% for commercial PPO. These revised goals recognize that there's different starting and ending points for payer. We also recognize that all arrangement will need a link to quality. They also create a glide path that more than triple commercial PPO member attributed to ACP land category 3 and 4 from 16% in 2021. And they also reinforce the need for prompt action by including public reporting on progress against biannual goals. OHCA may consider revision to APM adoption goals after the first 2 years of data collection, when a baseline has been established. With this baseline data, we can adjust if warranted. Next slide. The advisory committee had the following feedback on OHCA's APM adoption goals. Several members recognized the challenges of increasing APM adoption in PPOs and how this influenced the proposed goal. One member was concerned that the Medi-Cal adoption goals may be too ambitious. OHCA appreciate that different payer types starting and ending point for APM adoption will vary. Several members suggested collecting data from provider organization to understand APM adoption at the provider organization level and how provider organization pay downstream providers. Initial data collection and accountability will be at the payer level. OHCA is planning on collecting data from provider organization with restricted or limited knock-in licenses in the future. OHCA has not determined whether it will collect data from other entities in the future. And now we want to know, do workgroup members have any additional feedback on the APM recommendation or the advisory committee feedback?
Thanks, Nan. Sure, go ahead, Mohit.
Good morning, everyone. Mohit Ghosh with Anthem and Elevance Health. Wanted to just raise a couple of points around this that I heard yesterday during the advisory committee that are not necessarily reflected here. One is that I heard a pretty distinct discussion around provider capability in adoption of APM and necessary funding, incentives, et cetera. We do have some examples of this. In fact, for just looking at the Medi-Cal population as one area, we have been, thanks to the state, been able to provide IPP funding payments throughout this year at Anthem to a number of our provider partners to at least get them to be able to share data better, right? So anything around APM is very data heavy in order to be able to create the reporting. So we've been able to do that, but in light of the current budget situation and in light of monies being moved within the state budget, we don't know how much of that work can continue going into 25 and 26. So it really goes to that point about Medi-Cal adoption. The other piece within Medi-Cal alone is the FQHC system. Adopting APM in FQHC, there is a large effort happening at DHCS. So I'm hoping that the teams are talking, but the uptake hasn't been there because of the PPS structure, meaning if you're going to keep all payments essentially at the same level and try to create APM, what is the incentive for FQHCs that provide a significant amount of service and coverage for Medi-Cal recipients in the state of California to move in this direction, especially when they don't see a clear funding stream that can get them up and running? The last piece I would point out is that we need to really consider, again, from a budgetary standpoint, where the investments are coming from, how they line up with the OHCA cost benchmark. And I heard, Margarita, you mentioned very clearly that you're not looking for, canceling investments, but you're looking to see this move over time. And I think that's very relevant. But to that end, we also had discussion yesterday during advisory committee around the adoption of 1 and 2, category 1 and 2 payments as an entryway for providers to get on board. But we are still in this grid very focused on categories 3 and 4. So without being able to push people into that continuum, how do we get them to categories 3 and 4 over time? So those are my overarching comments on the APM and the discussion that was held yesterday at the advisory committee. Thank you.
Sure, thanks, Mohit. And I think just throughout we have tried in the standards, and appreciate if folks have additional suggestions to focus on encouraging small practices and ways for practices who may not be familiar with APMs, ways for payers and others to support those practices in APMs, and have focus on that we understand that there will be likely for many providers who may not be participating in APMs now, kind of a gradual progression towards category 3 and 4 that, and that contributes to the 10-year time frame for our goals, that not everyone is going to be in category 4 if they're not already in an APM, in the next few years, that we recognize that there is transition time, and that has influenced both our goals and our standards and all of the supplemental implementation guidance. So appreciate that emphasis and that feedback. And it looks like, Joe, you have some feedback as well. Go ahead.
Yeah, actually just questions for clarification. Excuse me, Joe Castiglione, Blue Shield of California. The first of which, my recollection, the last time I think we discussed this specific issue was that OHCA is still evaluating jurisdiction, I don't know the exact word, but whether or not you plan to collect data or include ASO in the denominator, or self-funded, I'm sorry, in the denominator here. So first question is whether you have a timeline for when you plan to make that decision, and then B, a question about the advisory committee feedback, whether or not there was any additional feedback on the decision to measure by membership rather than by spend, which, as I think, as you all know, is sort of been historically the standard, and is actually how LAN itself measures adoption of APMs. So first, ASO timeline, and then B, the use of membership versus spend.
Thanks, Joe. I don't have any additional or new guidance on the ASO question or the self-funded question at this time. And then I guess just a clarification on your second question. So we are planning to measure by % of members to an attributed APM. Are you suggesting measuring by spend or?
Sorry, yeah, that is something that we had wanted. That was a position that we had taken earlier on, was that we had wanted, you know, we felt it was more, especially given especially in PPO, it was more meaningful to do it by spend, but understand that you all have landed on measuring it by membership. My question is really about whether or not the advisory committee had any feedback on that specific issue. Again, the decision to measure by membership rather than by spend, which has historically been the national standard on how to measure adoption of APMs.
Sure. So, yeah, I think I'll note that we appreciate that, and we can, you know, as complementary information, we can report by spend or by dollars in an APM. So, our goals are set by membership based on kind of the philosophy we've talked about in terms of focusing on broad population health and making sure that we're involving members in APM arrangements to kind of support those broader population health goals. But we can report by spending as well. So that is something we would consider in terms of our reporting approach. And then okay, I don't remember it. It may have been in a previous advisory committee meeting, but if anyone else from the OHCA or FHC teams remembers if any advisory committee members had specific feedback on this question.
Margaretta, this is Mary Jo Condon. I did not hear any advisory committee member speak in favor of or opposed to the use of members as the unit of measurement.
Okay, thank you so much.
Sure.
Sorry, Margarita, it's just a point of clarification. The attribution would involve all membership, right? Not just members who use services. Just yes, to be clear, because that again changes the equation, because people who don't use services would necessarily not be APM'd in some way. But I understand where, yes, yeah. So the numerator denominator issue will come into play.
Yeah, and I think that's something we talked about with the advisory committee yesterday in relationship to kind of the context for setting a PPO goal that's lower than the HMO goal. And so, yes, that's part of our, thought behind setting a lower goal for PPO APM adoption is recognizing those attribution challenges. Any other thoughts or, sorry, let me just check the chat. Any other feedback on and or considerations as we review the advisory committee feedback?
Margaretta, I might just note a comment in the chat from Dolores, and this was a discussion point that we had earlier in a previous IPW meeting. And that was that data from IHA found that APM adoption, if measured by total cost or total members, basically resulted in the same findings. So the results were very similar using either one of those units of measurement. And that was true across all lines of business.
Thanks, Dolores. Appreciate that. Thanks, Mary Jo. So just wanted to reiterate what Non mentioned earlier, that because of board member schedules, we are moving a little quicker than we had previously anticipated to propose these goals and standards for board approval in our May board meeting, which is next week. And if, the board members have additional feedback or, we're not able to come to consensus, we'd come back to these goals and standards in June and would, of course, seek your feedback as well along the way based on any feedback we receive from the board. So welcome any kind of considerations or thoughts you all have before next week, but did want to emphasize that that is the plan for seeking board approval next week. And I think with that, we'll turn to primary care. So I'll turn it over to Debbie to walk through some background on our primary care investment, benchmark recommendation, and advisory committee feedback.
Good morning. You can go to the next slide, Margareta. So I'll start by reviewing this updated timeline for finalizing our primary care recommendations. This month, we're reviewing our benchmark recommendations with you all, with the advisory committee, and with the board. We released the primary care benchmark recommendation for public comment last month at the April board meeting, and we will be accepting public comment until May 31st. And then OHCA and Friedman Healthcare will be incorporating feedback received this month, including the public comment, into updates for both this group and the board in June. And ultimately, we'll present a final benchmark recommendation for board approval in July. Next slide. So here we recap how other states have approached some of the key decisions related to developing a primary care investment benchmark and how these decisions compare with OHCA's. As we've discussed in previous meetings, states tend to make the same or very similar decisions in these areas. For example, all states have set a single benchmark across all ages and have based their benchmark on the % of primary care spending. Most states have set an absolute benchmark and layered in stair steps or a relative improvement benchmark to offer milestones along the way. And as you can see here, OHCA is recommending a similar approach. Next slide. So here are 3 key lessons that we've learned from other states' primary care benchmarking efforts. The first is that the most successful efforts gradually reallocate spending toward primary care. If the timeline is too condensed, then the efforts to increase investment in primary care may accelerate growth in total cost of care. Second, 4 of the 6 states that currently have investment requirements only focus on either commercial or Medicaid, and not both, nor Medicare Advantage. And these states have found that sustainable care delivery transformation requires multi-payer alignment to give providers consistency in payment structure and expectations for care delivery. So several of those states are now working to bolster that multi-payer alignment. And finally, other states' experiences have taught us that increases in the total cost of care can hinder benchmark success. So as the total cost of care, which is our denominator, increases, then achieving primary care benchmarks that are based on a % of total medical expense becomes more difficult. Next slide. So as we're continuing to discuss the primary care investment benchmark, we want to emphasize the statutory intent that guides our work. OHCA's enabling statute specifies that the increase in primary care investment should be a shift or a reallocation and not an increase in costs to consumers or to the total cost of care. So this slide shows just one example of the math for that shift. Nationally and in California, we know that hospital services make up a significant portion of the healthcare dollar. So this national study puts them around 38%, which you can see in the navy blue. And meanwhile, primary care is at about 5 to 7% of spending in the green. So in this hypothetical example, if we were to shift 1% of total medical expense, or TME, from hospital to primary care, it leads to a small decrease in hospital spending of about 2.6%. But meanwhile, the resulting increase in primary care spending is much bigger, approximately 14 to 20%. Reductions in rates of avoidable emergency department use and avoidable hospitalizations are examples of how low-value care that can be addressed through greater investments in high-value primary care. So if we reallocate spending from low-value or unnecessary care to primary care, that could come from other sectors in the health system too, not just hospitals, but all towards the goal of providing access to the right care at the right time and in the right setting. Next slide, please. So we're aiming to balance the pace of change in primary care investment. The states in the graph here, Colorado, Delaware, Oregon, Rhode Island, and Connecticut, have the most experience in working to increase primary care investment. 4 of these states also have cost growth benchmarks. States often aim to shift primary care spend by approximately 1% of total medical expense per year, but experience finds that actual shifts in primary care spend are often more modest, especially when the early goals are more ambitious. The lessons learned from other states, as I mentioned, highlight that increases in primary care spending take time, and states' success in increasing primary care investment tends to track with the level of transparency on investment within the state and also the other accountability mechanisms that are included. So Rhode Island has seen steady increases in primary care spend since 2008, and Oregon has seen overall growth since 2014, while Colorado hasn't seen much movement. In Delaware, a greater focus and a state requirement has led to more progress in recent years, which you can see in the blue. Excuse me. Sorry. Delaware is green. And then on the other hand, in Connecticut, growth in total medical expense has outpaced increases in primary care investment in the commercial market. And you can see the flat in the light blue. Next slide. So the de-identified data here, which is from the Integrated Healthcare Association from 2021, shows primary care as a percent of total spending by plan product type within the commercial market. The primary care spending among HMO plans in the darker blue tends to be higher at an average of 9.2% than among the PPO and EPO plans in the light blue, which averaged 6.3%. You can see that both types of products had a broad range of investment across plans. And for reference, the HMO population shown here represents approximately 8.8 million lives, while the PPO and EPO population is 4.8 million members. Next slide. So you may remember this slide from a prior meeting. It shows data from the Integrated Healthcare Association that demonstrates the differences in primary care spend for children and adults among commercial and Medicare Advantage plans between 2019 and 2021. The dark blue bars show how the percentage looks when the commercial populations are combined. And as you can see, primary care spend for the commercial adult population in light blue and pediatrics in royal blue differs substantially, with adult spend averaging 6.2 to 8.7%, while pediatric spend was more than double that at 18.4 to 21.1%. However, the percent primary care spend for Medicare Advantage, which is shown in green, is fairly close to the combined commercial spend, which averaged 7.3 to 9.9%. It's worth noting that the primary care spend data from IHA uses a slightly different methodology from what OHCA is proposing, but these spending data give us a directional understanding of current commercial primary care spend. Next slide, please. You may also remember this slide, which shows that Medi-Cal health plans spent an average of 11.3% on primary care services in 2018. And again, there's quite a bit of variation across populations, with an average of 28.2% primary care spend for children compared to 11.6% for adults. And again, I want to highlight that this Medi-Cal report used a different data source and a different methodology than OHCA is proposing. And we expect that the percent investment calculated by OHCA will be lower than what was calculated using this methodology. Next slide, please. So after much discussion, OHCA has landed on recommending a single absolute benchmark based on the age distribution within the state, with a relative improvement benchmark that reflects annual increases in primary care spend. In the future, OHCA will conduct analyses using the Healthcare Payments Database, or HPD, to understand pediatric and adult primary care spending and to consider whether non-claims payments can be allocated to age groups. OHCA plans to report on its progress towards the absolute benchmark annually. And to provide context, OHCA can report changes in primary care spending along with the population distribution by age for each payer. Next slide. So based on all the feedback we've received, and in particularly the need to limit data collection complexity, this is OHCA's benchmark recommendation. OHCA is proposing a relative improvement benchmark for payers to increase primary care spending by 0.5 to 1% per year, depending on their current level of investment. And in tandem, OHCA is proposing a statewide absolute benchmark for California to allocate 15% of total medical expense to primary care across all payers and populations by 2034. So to begin with the rationale for the relative improvement benchmark, this is consistent with the approach of other states, many of which began with a relative improvement benchmark to acknowledge that payers are starting at different places and also to promote a gradual reallocation of spending. For the absolute benchmark, the 15% number is slightly higher than other states in recognition of California's healthcare delivery goals, delivery system structure, and younger population, as well as the time horizon out to 2034. We know that states with higher primary care investment have been found to spend less on avoidable hospitalizations and ED visits. And the 15% absolute goal is also consistent with high-performing health systems internationally. The 2034 timeline aligns with our recommended timeline for meeting the APM adoption goals to acknowledge the connection between APM adoption and primary care investment. APMs often support advanced primary care, and quality performance in an APM is frequently tied to primary care services. Next slide. So the advisory committee at its meeting yesterday had a number of supportive and helpful comments on OHCA's primary care definition and benchmark recommendations that I'll review in these next two slides. So first, several members supported the 15% benchmark, and one commented that the timeline offered a nice runway. Several members recommended separate adult and pediatric investment benchmarks to ensure adequate spending for both age groups. They cited concerns about potential stagnation of pediatric primary care investment under a single benchmark. No other state has reported this kind of impact from a single benchmark. And as we've noted in prior workgroup meetings, OHCA believes that the data submitter burden and inaccuracies inherent in attempting to divide primary care allocations for non-claims payments into adult and pediatric portions make a single benchmark the best option. OHCA expects that primary care investment will increase across all age groups under the single benchmark, and we will consider using HPD analysis to monitor primary care spending by age group. Also, OHCA's reporting will include plans, population age distribution, as I mentioned, that will contextualize their spending levels based on their population. A third area of feedback brought up by several members was that the formula to allocate a portion of capitation to primary care would not capture all provider organization spending in support of primary care. One member suggested testing the formula that we've proposed with payers and providers. And so as we've discussed previously at workgroup meetings, payers have limited insight into how providers allocate funds internally, such that we expect that our methodology will likely both underestimate and overestimate the true allocation depending on the provider group. We recognize that no formula will capture this spending perfectly, and we continue to solicit feedback on the formula for allocating capitation payments to primary care. We can go to the next slide, please. So one member noted that the 10-year timeline we're proposing is fairly long and would like to see most of the increased investment happening over the first few years. OHCA anticipates that its annual reporting on the relative improvement benchmark and its absolute benchmark will promote near-term improvement as well as long-term success with these goals. And then secondly, similar to what we discussed about APMs, several members suggested collecting data from provider organizations to understand primary care spending by those organizations downstream. And as Non noted earlier, our initial data collection and accountability will be at the payer level. OHCA is planning to collect data from provider organizations with restricted or limited Knox-Keene licenses in the future, And OHCA has not determined at this time whether it will collect data from other entities in the future. And then finally, several members suggested that OHCA should track complementary measures for primary care investment, such as PCP consumer relationship, continuity of care, and quality. OHCA is exploring additional analyses using the HPD to understand the connections between increased investment and those outcomes. So at this point, I'll pause for your input. Do you have any additional feedback on the primary care investment benchmark or the advisory committee feedback? Feel free to raise your hand.
Thanks,
Okay.
Mohit.
Yeah,
Yeah, go ahead.
You know, I sound like a broken record, but I'm going to say it again. As we go down these definitions and understand the goal ultimately of what primary care needs to look like in the state of California on a teams-based approach, I still think we would be doing the public a disservice if we do not calculate all spending in primary care, regardless of the site of service. I think that's just an important table-setting fact that we need out there to be credible in how we do the transition to more teams-based care. So I'm just going to make that point. And I think that's already emphasized in the presentation that we've seen today when, you know, OHCA is looking at Medi-Cal primary care spend, recognizing that you will not be counting certain elements in that Medi-Cal primary care spend in your own calculation. So just given that example alone, that covers 14.5 million people in the state of California, having a level of credibility for our baseline is extremely important. So I'll just make that point. And then there's some very interesting discussion in the chat about what is included and isn't. The prescription drug issue, you know, we brought it up very early. Immunizations, the actual cost of the drug versus the administration of the drug, et cetera. You know, I'd love to have OHCA staff respond to the discussion on Colorado and other states in the chat. Thank you.
Sure. Mary Jo, do you want to go ahead?
Sure. Thanks for the discussion in the chat. And also just want to clarify that the discussion in the chat is related to whether or not pharmacy is included in the denominator, not in the numerator. So it is not customary across states to include any pharmacy spend in the numerator. What is happening in the chat is a discussion of what is included in the denominator. And I can, you know, talk through, but essentially Rhode Island, Connecticut, sorry, I'm looking up at a list, Massachusetts, Maryland, Maryland now excludes pharmacy from the denominator. Washington, IHA, Millbank all included pharmacy in the denominator. Roughly the same number of states exclude pharmacy in the denominator. It's sort of a mixed bag, and it really goes back to what's most sort of congruent with how that state is handling total cost of care. So for example, states that are including pharmacy in broader conversations of total healthcare expenditures often include pharmacy in the denominator of their pharmacy spend, but want to be really clear that what's being discussed in the chat is related to the denominator, not the numerator.
And I think I would just flag that I think especially important is that when looking at the California data from IHA, that pharmacy is included in the denominator there. So that I think that should give us at least, you know, good directional estimates that how we plan to measure at OHCA will be directionally aligned with the approach that IHA took. And yeah, Carrie, go ahead.
Thanks, Margareta. I just want to, you know, reiterate my support for this direction. I think, you know, taking the 15%, I know is, you know, is aspirational, but it's really important in order to move our spending, particularly, around adult primary care, to something more in line with, other states, other countries. When I look at this slide, and I see the huge difference between primary care spend on the percentage on children versus adults. It also, just to me, becomes really clear, why we really need one benchmark. I think, without that, we're sort of, looking across the population and maybe missing where we really need to focus, which is and bringing up the access to primary care, particularly for adult populations who, are just not getting, are paying for insurance, but not getting in to see the doctor, actually getting the care they need. So I just wanted to, put my comments out there. Thanks.
Sure. Thanks, Carrie. Do other folks have thoughts or kind of reactions to any of the advisory committee feedback? Yeah, Mohit, go ahead.
I actually have a reaction to a slide that was a little bit early on the kind of the ratio of 1% reduction in hospital spend moving into primary care. I think it's important to recognize that there's a strong element of, just pure healthcare utilization involved there, and also for consumer preference of where they go to seek their care. So while people might show up at the ER to get a primary care issue resolved, as we sometimes see, that's, could be because they couldn't find a primary care physician, or they're in an area where the hospital is the closest place to them. So as we try to meet people where they are, again, goes back to calculating primary care spend in a way that allows for, all of it to be counted. So that's one area. The second is, I don't, the last thing any of us want to do is to dissuade any types of benefit structures or coverages that would prevent people from seeking the care they need when they need it. So I want to be careful that the hypothetical, even that was put up on screen, needs to have some basis in market reality. Like, how do people actually behave? And yes, over time, that is possible to move people as they get more into primary care. But I just wanted to make that observation that there's a huge element of the medical marketplace at play here that is not simple to solve just by reallocating capital.
Thanks, Mohit. Yeah, I appreciate that this is not a simple adjustment or reallocation that we're looking for, that this is really a kind of a transformation in care delivery that we're looking for. And, we want to, increase access to primary care when needed, so that folks don't need to use emergency services when it's not, when they really need a primary care service. So, and we recognize that, that will take time, and that weighs into our recommendation for a 10-year timeline. And I know we had a few other comments, so I'll let Kevin go ahead.
Thanks. Let me be brief just to really echo what I see Catherine's comments in the chat here. Debbie, first of all, thanks for such a succinct and informative summary. And it's actually very heartening to me to see the advisory committee feedback, where it seemed in general to be very supportive and not detecting some huge flaw or something that we totally missed as a committee, and folks at OHCA for all the work on this. So I find this very gratifying, and I'll just close by saying I am very supportive of the recommendations moving forward as drafted. Thank you.
Great, thanks, Kevin. Monica, go ahead.
Yeah, thanks. I agree. Second the comments on a great presentation, and really thinking about what Mohit was sharing. Just two stories. So I'll tell two stories. So I think it helps ground us in the importance of this work. One, I was talking about the primary care spend work we've been doing with some Covered California colleagues who are youngish, and that, what we want to have happen in primary care. And both of them shared that they had never had a primary care experience like the one I was describing. They didn't have a continuity relationship. They didn't feel like if they messaged their provider that that person knew them and cared about them and would prevent them from going to urgent care. And so how tragic that we have a system right now where that isn't happening. And I think it's frankly not consumer desire to go to urgent care or emergency room. It's just kind of what's happening on the ground. And then I'm doing urgent care right now. And so last week had just this like fascinating experience where really everybody I saw wanted to and needed to be in primary care, but because of a number of issues, ended up with me. So one was someone with a huge, gigantic inguinal hernia, so bad they couldn't walk, and had gone to the emergency room and got bounced around and couldn't get into their specialty care because they really were struggling to access primary care. Another one was a gentleman with ulcerative colitis who was having 6 bloody bowel movements a day and really didn't have primary care. That person doesn't want to be in urgent care for their issues. Another person, huge, gigantic, like this big, lipoma on their back, who had primary care who really hadn't followed up on it. So I think when we talk about like what do consumers want and what do we see happening in the market, oh yeah, we see folks going to urgent care and emergency, but it is not because they want to be, right? Folks want to be in primary care and want to have those relationships. So it's true. I'm not sure that like this policy alone is going to get us there. There's a lot that needs to happen on the ground level, but this is such an important step. And so just like thankful for the work we've all done together to get us here, and remembering like these are people we're talking about who are struggling.
Thank you, Monica. Yeah, really appreciate sharing that context and those stories. And I think it really grounds us in what we're all working towards is not just increased investment, but increased access and getting investment to lead to better access and changes in the delivery system. Any other thoughts before we wrap up with a few more slides? Okay, I think Debbie, I'll turn it back to you for the next few slides.
Great, thank you for everyone for all that input. And so just to wrap up on primary care, I wanted to emphasize how the primary care investment benchmark and the APM goals are interrelated. OHCA is recommending a shared timeline for APM adoption goals and the primary care investment benchmark. And we expect that this emphasis on slowing spending growth that we'll be seeing will motivate investment in flexible primary care revenue streams via APMs, and that the value that's generated from APMs will allow for continued investment and reallocation of the healthcare dollar to primary care to meet these 2034 goals. So just highlighting the interconnectedness of all the work we're doing. And you can go to the next slide. So we greatly appreciate all of your input over these past 6 months to get us where we are with OHCA's primary care investment benchmark. And for the next steps for this work, I just wanted to flag 2 items. First is that the primary care definition and benchmark recommendations are currently posted on the OHCA website for public comment. Public comments can be submitted until May 31st at 5 p.m. Pacific time. So please feel free to encourage your organizations or others to share any additional feedback through the public comment process. You all can also email feedback directly to Margareta, and that will be considered work group feedback. And then the second item is a request for workgroup members to review the draft primary care definition code set that Margareta emailed to you on May 9th, last Thursday, and to provide us feedback by May 31st on the questions listed here. So are there any codes, types of providers, services, or places of service listed that you think don't align with our recommendations? And then conversely, are there any codes, providers, services, or places of service that were recommended by OHCA but that you don't see included on the list? And of course, we welcome any other feedback you have on the code set. So please reach out with any questions, and we look forward to your feedback. And next, I will turn it back over to Margareta to introduce our transition towards behavioral health investment over the next few months.
Sure. Thanks, Debbie. So we wanted to kick off today's discussion, or just introduce our work on behavioral health investment in the next few slides. So we'll just provide a preview of our timeline and the types of kind of questions and decisions we'll be aiming to make with our behavioral health investment work. So as I mentioned earlier, we are expecting our work on behavioral health investment to begin like more focused or officially in July in the next few months, and wrap up in May of 2025 with OHCA potentially seeking board approval of our primary care investment benchmark. So the OHCA team will make recommendations informed by the work group discussions to the advisory committee and the board several times, just as we've done with alternative payment models and primary care, and make adjustments prior to approval based on all of those discussions, leading up to seeking potential board approval of our our behavioral health investment benchmark in May of 2025. And just provide some context, excuse me, for our behavioral health work. So of course, this is guided by our legislative requirements and legislative intent, and it's outlined on these next two slides. So the behavioral health investment work is framed very similar to our primary care work in statute. So in terms of behavioral health, OHCA is statutorily required to measure the percentage of total healthcare expenditures allocated to behavioral health and set spending benchmarks to determine the categories of providers, specific procedure codes, and non-claims payments that should be considered when determining the total amount of spend on behavioral health. And then to build and sustain methods of reimbursement that shift greater resources away from specialty care and towards primary care and behavioral health, to make sustained system-wide investment in behavioral health, and include an analysis of behavioral health spending and growth in our annual report, and to consult with state departments, external organizations promoting investment in behavioral health, and other entities and individuals with expertise in behavioral health, which is what we aim to do through this work group. And then also the statute provides a bit more guidance in terms of how we should seek to promote improved behavioral health. So statute emphasizes supporting integration of primary care and behavioral health, improving access to team-based care for behavioral health, reducing disparities in behavioral health outcomes, and expanding access to behavioral health services. And on this next few slides, I'll provide like a bit of context and some of the questions we'll consider as we move forward. So on this slide, wanted to share a figure from Milbank Memorial Fund's recent report, which is recommendations for a standardized state methodology to measure clinical behavioral health spending, which is written by the team at Friedman Healthcare. So we're very excited to build on this work. So this graphic outlines different components of behavioral health spend for states to consider when measuring spending. So included in the graphic are service types, so either clinical, represented by the gray circle, or social support services, which are represented by the green circle. Funding type, either claims, shown in those orange circles, or non-claims-based spending, shown in the yellow circles. And then the payment mechanism, either a healthcare payer in the light blue circle, or state budget, which is in the dark blue circle. And then the lighter blue dashed line highlights that Medicaid funds behavioral health services as a payer and is also funded by state budgets. And then in the middle, in that gray text, you have a reference to patient out-of-pocket spending. So, that could potentially occur in a few ways, whether it's the patient cost share for services under insurance coverage, or seeking self-pay services, potentially due to a lack of coverage or a lack of available in-network providers. So I just wanted to kind of walk through how we might think about using this these components and looking at how we would measure behavioral health spend. So we recognize that each cluster represents an important part of behavioral health spending. including spending by payers, payer spending on social supports for individuals with behavioral health needs, and behavioral health services funded by the state. And we anticipate starting with this top cluster, which is highlighted in the blue box. And that's behavioral health spending funded by public and private payers. So starting here will support us in understanding behavioral health spending as a percent of total healthcare expenditures through our total healthcare expenditure data collection. So this measurement would include payments from traditional healthcare payers like commercial payers for most behavioral health clinical services. And then once we have an understanding of these services, the clinical payer-funded behavioral health services, we may look to measure or potentially review for context the spending in these other buckets, these other clusters like social support or state budget. But we want to start with the behavioral health clinical spending. And our focus for the work group will be on discussing how to define and set benchmarks for the behavioral health clinical spending. So this next slide just provides some examples of what we kind of the topics we'll plan to discuss, and you'll see parallels to what we've been discussing for the primary care investment benchmark. So, we'll talk about use cases for measuring behavioral health spending, how behavioral health services are delivered and paid for in California, and how these factors impact our spending measurement, how other states have measured behavioral health spending and considerations for California. So we'll walk through, diagnoses, providers, provider types, services, care settings, and non-claims measurement approaches that other states have used, and how we might adopt or adapt those to use in California. And then, of course, key decisions for setting a behavioral health spending benchmark. So wanted to kind of wrap up here, and happy, since we have some time, we, unlike some of our other meetings, wanted to solicit some kind of information or feedback from you all, and we would appreciate any suggestions you have now or via email. So thinking about from all of your expertise and perspective, are you aware of behavioral health spending measurement or related research occurring in California? How do you see the structure of the behavioral health delivery system and payment systems in California informing our work? And then are there other topics that we kind of haven't covered today that you think are important for the work group to discuss? So I'll come back to this slide, but just real quickly to reiterate in terms of our next steps. We sent an email recently asking work group members to confirm they'd like to continue their participation starting in July to focus on behavioral health. So we would appreciate your response to that if you haven't already by May 31st. And then also, if you recommend transitioning your role to another member of your organization who has more intense or kind of deeper expertise in behavioral health, we'd welcome that. And again, would welcome that note by May 31st. And then in our July 24th investment and payment work group will be our first meeting fully dedicated to behavioral health. So I'll go back to kind of seeking your feedback and suggestions. So, and it looks like Sarah. Go ahead.
Hi, can you hear me?
Yes.
Okay, great. I'm really excited for this next stage of the work group, and feel like I've benefited a lot from listening to the primary care discussions, and we can launch from the learnings and in that discussion into this behavioral health discussion. I do think that one of the challenges with the behavioral health discussion is how different the payer, how different the benefit sets are by payer. And so I think it's important to look at all of them, but figuring out in our discussions how to compartmentalize the discussion in some way from commercial, Medicare and Medicaid, or Medi-Cal, with not sort of not giving one more focus than the other, but making sure that we don't conflate them sometimes, because they are just they pay for different things. And so that'll be, I know that the Millbank work has already looked at this, and we have a starting point from which to launch, and looking at what other states have done. But this is a challenge. California has a very unique behavioral health system on the Medicaid side, but this is a challenge in most states, that the benefit sets are just often different. So I just want to highlight, maybe pointing out the obvious, but I think I didn't want it to go unsaid.
Thanks, Sarah. Yeah, we definitely think we'll need to be looking kind of across all different payer types and benefit designs, and maybe have like distinct focus conversations about commercial, about Medi-Cal, about Medicare, and kind of thinking about how they are similar or dissimilar, and have all the different nuances across those payer types. Catherine, go ahead.
Yeah, building on Sarah's comments, in addition to the different sort of payers and systems, there's also some unique issues and I think real challenges historically with how behavioral health has been fractured and siloed, and would recommend, as this group sort of reconvenes, and particularly as we bring on potentially new members, as you offered, either additional from similar organizations or potentially some new organizations, to not restart, but revisit some of the principles and values that we established early in our process for primary care, and really consider updating, expanding, revisiting them on behalf of behavioral health, so that it's clear as we're moving ahead how we're going to sort of solve for some of those historic fragmentation and silo issues. For example, SUD care, substance use disorder care, has not just been fractured from physical care, but even from mental health care. And there are different providers, there are different settings, there are different payers, there are different systems that are involved in that. That seems important to consider. We spent a lot of time thinking through in primary care which providers ought to be included in the definition, what settings ought to be included in our definition, and what services or codes sort of undergird that. In behavioral health, it's even more complicated because we have severity, who's in charge of mild to moderate versus severe conditions. So I think all of that, you had a lot of bubbles, and there's even more, I think, to consider as we really wrangle a definition that fits and feels right and really lives into the definition of whole person integrated care. So we just encourage us to think through those. No solutions or recommendations to offer today, but just to make a little bit of space for that process, so we're sure this new formation of the group really holds the same definition of behavioral health integration, and all that it ought to include.
Great, thanks, Catherine. Any other, and Bill, thank you for the recommendations of different provider organizations. We'll definitely look into those and reach out to follow up. And yeah, any other thoughts or suggestions for as we're kind of digging in to launch and preparing to launch our behavioral health work? Go ahead, Sarah. Yeah.
Yeah, maybe one more comment is that even sort of in initial settings, the commercial side and the Medi-Cal side they're just so different. And they like cultural, it's primary care generally is kind of the same, on Medicaid and commercial. And I think even just some level learning across between those systems of each other could be helpful at the beginning. I think especially having almost a presentation from a commercial payer or commercial system around how benefits are organized and paid for to the Medicaid side could be a good level setting, and vice versa. And then even on the commercial side, really going into the difference between like employer-based sort of the self-insured direct to employer, and we explaining what self-insured is, right, to on the Medicaid side and the difference, and like what those like how employers pick benefit packages on behavioral health, because it's often different, right? Like there are many more carve-outs, but versus like fully insured products, and that landscape overview could be really helpful to new work group participants coming in.
Yeah, and I would say probably helpful to a lot of us, not just at least helpful to me as we move forward. Kevin, go ahead.
Yeah, I mean, I think Sarah is elucidating so many of the things, as well as Catherine. I mean, this is going to be really, it's so multifaceted. I think this is going to be a whole other level of complexity. And I think Catherine also pointed out the patient population is across such a broad swath, from people with severe mental illness to people with substance use disorders to people with, depression, anxiety, a lot of which is going to be embedded in more primary care settings or other sort of non-dedicated behavioral health settings. So it's going to be tricky. And then, I guess Mary Jo, your group did that figure, or that, there's that dotted circle in the middle that is unfortunately particularly pronounced in behavioral health, which is out-of-pocket consumer payments. I feel like I have to channel Beth Capel, who I don't think is on the call today, but this is an area, if we're not ultimately trying to account for direct patient payments, and because so much of this is just people pay directly out of pocket, and it's, again, and it differs for the types of services, the types of patients, but I don't think that's going to be the initial part of this, Margarita, right? That's going to be the hardest to track down, but starting with sort of health plan payments to capture that. But that is going to be a very, very large component of total behavioral health spend is going to be directly paid by patients, I think. And that's going to be really elusive to try to, I think, get our hands around.
Yeah, that's very true. That we are OHCA as a whole, especially in terms of our work to measure total health spending, are looking into this issue, and I think we've many groups, our advisory committee and our board and this group have recognized that it's especially a challenge in behavioral health. So there is some ongoing work at OHCA to try to measure kind of consumer out-of-pocket, out-of-plan spend, or out of plan coverage spend. So that is something that we are looking into and can pull in learnings from that work, and also dig into it deeper as it relates to behavioral health. Yeah, it's a very big kind of challenge and gap in terms of what we could measure and or how we could try to estimate. Okay. So I think we have a little bit of time left. Any other questions, suggestions, feedback on anything we've covered today? Okay. Well, thank you all for the feedback and the discussion on alternative payment models and primary care. We'll continue to work on those and provide you updates as we move forward. And then, yes, if you have any resources or suggestions for behavioral health, please feel free to send them our way. We'd appreciate those as we get started on behavioral health. And I'm sure we'll be in touch before our next meeting, but we will see you in June. And one note that our June meeting has been rescheduled due to the Juneteenth holiday. So did want to make sure that everyone got the rescheduled June meeting on their calendars. So thank you all, and appreciate all the great discussion, and we'll talk to you soon.